Okay, we're going to talk about some obstetric and gynecologic emergencies. They're few and far between as an EMS provider that you are called for a woman with a gynecological emergency to include childbirth in the home, but it can happen. So we're going to cover all types of obstetric and gynecologic emergencies in two parts. So part one. We'll start first with some anatomy and physiology review of the external genitalia in the female, which consists of the labia, which is the outer fold of skin that protects the vaginal opening, the perineum, which is the space between the vagina and the rectum, and the mons pubis is the fatty pad on top of the pubic bone where pubic hair grows. The vagina is referred to as the birth canal and is made up of smooth muscle. And within the remaining internal genitalia in the reproductive system, we have the ovaries and the fallopian tubes, as well as the uterus. Now, the ovaries are responsible for producing ova, or an ovum would be one egg. An ova would refer to, multiple eggs. And the ova is produced and travels to the fallopian tubes through the oviducts, where usually fertilization would occur if there were semen in the fallopian tubes. Now, what can happen sometimes is the ovary, which typically is fertilized in the fallopian tube and then travels down into the uterus where it attaches to the uterine wall. Sometimes the ovum will attach itself to the fallopian tube, and that's called an ectopic pregnancy, or a pregnancy that occurs actually outside the uterus in the fallopian tubes. And now a fallopian tube obviously isn't large enough to carry the developing fetus to term. So typically early in the pregnancy, as the fetus begins to grow, the fallopian tube will burst. There may or may not be excessive bleeding. It really depends on where the blood goes. There is a sac behind the uterus where blood can collect, and it may not come out of the vagina. However, if blood does gush out of the vagina, it can be significant enough to cause shock and even death as a result of lots of blood loss. The uterus is a muscular hollow organ that's located along the midline of a woman's lower abdominal quadrants, and it is the intended site for the fertilized egg to implant itself and then develop into a fetus. The uterus will stretch and grow as the fetus gets larger. The cervix is a muscular ring that separates the uterus from the vagina, and that will, under normal circumstances, remain closed until it's time for the fetus to be born, at which time the muscular ring thins and dilates, allowing the mother to push the fetus out of the uterus. So here's just a diagram of some of the stuff that we certainly talked about, with the ovaries producing ovum that will be discharged into the fallopian tubes. And again, if there is semen in the fallopian tubes, the fertilization of the egg occurs, where it then travels down into the uterus, where it attaches to the uterine wall, and initially the egg begins to develop, and at that point also the placenta begins to develop as well. Now, when we look at the female reproductive cycle, menses is the name given to the period. Menstruation is stimulated by estrogen and progesterone. So those hormones stimulate menstruation. The ovaries release the ovum, the uterine wall thickens, the fallopian tubes move the egg by peristalsis the egg, if it does not become fertilized and it does not attach itself to the uterine wall as a fertilized egg, then the uterine wall sloughs off and expels itself, which presents as bleeding for 3 to 5 days. Now, bleeding could be spotting, bleeding could be significant. There are times when women during menstruation will have heavy menstrual flow, which may make them slightly anemic. Now, fertilization, again, as I mentioned, occurs when the sperm reaches the ovum. The ovum eventually becomes an embryo. The embryo implants itself in the uterus, and then the fetal stage begins. Now, during the development of the fetus, there are physiological changes that occur in the mother during her pregnancy, which is divided into 3 trimesters. And during each trimester, we start to see specific physiologic changes that may make it more difficult for you to recognize when the mother's in shock, or make it more difficult for you to manage her airway, or to even transport her. So the reproductive system is divided into 9 months of pregnancies, so 3 3-month trimesters. And we already mentioned that the placenta is the organ of maternal and fetal tissues that allow for the exchange between the mother and the fetus of oxygen and nutrients. Now, the blood barrier between the fetus and the mother is pretty significant. Some things will pass, like medications, like alcohol. Certainly illicit drugs may pass into the fetus, causing birth defects. The umbilical cord circulates blood, and at birth, the baby's delivered first, and then the placenta is delivered after that, with the umbilical cord connecting the baby to the placenta. Now, the amniotic sac is a sac that the fetus grows in. It is filled with amniotic fluid. The fluid helps cushion the fetus, helps maintain constant fetal body temperature. So it has a very important purpose. Now, one of the things that occurs early in the stages of labor is the amniotic sac breaks. There may be a flush of the mucus plug in the cervix, which is called bloody show. And there might be a gushing of amniotic fluid out of the vagina. But the amniotic sac doesn't always break. And the baby may be born in the amniotic sac, in which case the sac has to be torn so that we can get the baby out of the amniotic sac. So this is just certainly a diagram that shows the structures of the mother in pregnancy, understanding here that certainly in this particular position, the baby is engaged head down, getting prepared for delivery, but that's not always the position in which the fetus lies in the mother's womb. Some other physiologic changes that occur in pregnancy is that by the 3rd trimester, the female has increased her blood volume by 45%. So she has a 45% more blood volume. Her cardiac output then increases. Her heart rate has to increase in order to circulate blood to the developing fetus. But even though her blood volume increases by 45% by the 3rd trimester, her red blood cells do not increase by 45%. As a result, with the amount of blood she has, she doesn't have enough red cells in that blood. So she is slightly anemic. The other thing about that excessive blood volume that does occur, or again, 45% increase in blood volume by the 3rd trimester, is that the mother, particularly in the 3rd trimester, can lose a lot of blood before you start to see any signs or symptoms of shock. With the respiratory system, you can imagine that there's an increase for oxygen demand and consumption, because now you have 2 people who are metabolizing off of one, so her respiratory rate will increase. It does so to get more oxygen, but as the fetus develops and puts pressure on the diaphragm, it becomes difficult for the lungs to expand fully. So what you see, again, as we get longer and longer into the pregnancy, is that the mother has to take more frequent shallow breaths in order to keep up. The gastrointestinal system, initially in the first trimester, there might be some morning sickness with some nausea and vomiting, which typically goes away. But as the pregnancy develops, the digestion slows, the GI tract slows way down, and the mother may find herself eating small amounts more frequently and may have a full belly. Literally full of baby, and also her stomach may be full, even though she had eaten hours earlier. The ligaments are made more elastic, and therefore the mother is more vulnerable to injury. The mother is more vulnerable to injury. The developing fetus is well protected, and it takes a significant amount of trauma to injure the fetus in that developing uterus surrounded by that amniotic fluid. The additional weight in the mother's abdomen certainly can affect her posture, can lead to back pain, can lead to balance issues, perhaps falls. And if the mother had any sort of pre-existing medical conditions, certainly the pregnancy can make those worse, like asthma, COPD, diabetes, those sort of things. So here is just a photo that illustrates some of the physiologic changes that occur in pregnancy. Keep in mind, too, that, as the belly enlarges and the developing fetus grows inside the uterus, the mother often puts on weight, and some women put on far more weight than others. So there's a lot of additional soft tissue that may make it more difficult to manage her airway if she's got a lot of additional soft tissue. Breasts become enlarged, which actually does affect the ability to manage the airway as well. And we'll talk about what happens when you take this woman, particularly in her third trimester, and lie her flat on her back. That's called supine hypotension syndrome. If you take the mother and you lie her flat on the back, the placenta, the infant, the amniotic fluid, somewhere in the neighborhood of 20 to 24 pounds, compresses the inferior vena cava, the major vein that delivers blood from the lower part of the body to the heart. And as a result of that, you have less blood coming to the heart, less blood going out, cardiac output decreases, and it causes a drop in blood pressure. And the drop can be significant enough to cause symptoms in the mother. Now, we're going to talk a little bit about labor and delivery, and then that should take us through this first part, and then we'll get into complications associated with delivery. Now, the first stage of labor, labor is divided into 3 stages. The first stage starts with regular contractions and ends with the cervix being fully dilated. Now, women may experience something called Braxton-Hicks contractions, which are a spasm in the low back, can often be mistaken for labor. But once labor begins, certainly mothers will tell you there's no mistaking the cramping that occurs as the uterus attempts to expel the fetus. So it starts with regular contractions, and the first stage ends when the cervix is fully dilated. That's not something that we're going to measure or determine. An OB nurse or a physician certainly can, feel inside the vagina to the cervix to see if it is thinning and if it's dilating. And if it's fully dilated and thin, then we know that the second stage of labor is about to begin. That's when the baby enters the birth canal and is actually born. So entering the birth canal or entering the vagina and then being born outside of the mother's body is the second stage. The third stage begins after the baby is born, and it ends when the placenta is delivered. Braxton-Hicks contractions are irregular, not sustained, and not indicative of impending labor. Lightening is when the fetus's movement from high in the abdomen pushes down towards the birth canal. Contractions of the uterus produce these normal labor pains. And again, there's no mistaking the type of pain associated with a contraction of the uterus as compared to Braxton Hicks or lightning. Characteristics of your labor pains, you want to note the contraction time or duration. So how long has the contraction lasted and how frequently are they occurring? When they last 30 seconds to a minute and are 2 to 3 minutes apart, then the delivery of the baby may be imminent and you may not be able to transport the patient to the hospital. The amniotic sac may break and there may be bloody show, and the amniotic fluid may expel out of the vagina. But if the baby has had a bowel movement, which the baby may do right before birth in the amniotic sac, the baby's first BM or first bowel movement is kind of like a thick pea green soup. And it may, if that's what you see coming out of the vagina when the amniotic sac breaks, that's called meconium staining, because meconium references the name given to the baby's first bowel movement. And if the meconium staining exists, then that may indicate that, particularly on delivery, that the baby may be at risk of aspirating that. So here's the first stage, there's the second stage, and there's the third stage laid out in a diagram there. The second stage is full dilation of the cervix. The contractions begin to increase more frequently. The pain becomes more severe. The mother will feel the urge to push or move her bowels. As the baby moves down the birth canal, the weight of the baby's head is going to put pressure on the colon or the rectum. And if the mother has a stool in her colon or near her rectum, she may actually have a bowel movement while trying to have the baby. The EMT has to decide whether there's time to transport the patient or whether you need to keep her there and prepare to assist with the delivery. Now, we're going to base that on a couple things. One is the frequency and duration of contractions, but also the presence of crowning. If the mother is crowning, or the baby's top of the baby's head is trying to push its way out of the vagina, then there's no time for you to load the mother up and take her to the hospital. You'll need to prepare to assist with the delivery in the home. Now, most deliveries in a home are precipitous. In other words, they occur very fast and with little complication. During the second stage, which includes the delivery of the baby, as the mother pushes and the head comes out, the head will pop out, and you want to turn the head slightly to the side. And at the perineum, right where the head is just out of the vagina, you're going to want to suction the mouth and then both nares. You want to start with the mouth first and then both nares with your bulb syringe out of your OB delivery kit. You want to do that because as long as the baby is inside the vagina and the chest is being squeezed, they're not going to take their first breath. But as soon as those shoulders and chest are delivered and the rest of the baby comes out, that decrease in weight and pressure on the chest, it'll encourage the baby to take their first deep breath and cry. After the baby's birth, contractions resume and they continue until the placenta is delivered, which is the third stage. Now, the delivery of the placenta usually only takes about 10 to 20 minutes. If it's taking longer than that, then you probably want to load the mother up and transport her to the hospital. So here's an example of a placenta that begins to appear out of the vaginal opening. Now, what you want to make certain of that you don't pull on that umbilical cord to try to get the placenta to come out faster. It is going to work its way out. It is necessary that you collect it all and bring it with you to the hospital so that they can make sure that it's complete and there's not any part of it still left in the mother, which certainly could cause problems later down the line. Now, as far as patient assessment goes, you want to first assess the mother and then assess the baby. Assessing the mother in labor is determining whether or not delivery is imminent. You want to get things like perhaps the name and age of the mother as well as the expected due date. Is this her first pregnancy or not? Because typically first pregnancies labor may last for 24 hours or longer. Has the patient seen a doctor during her pregnancy? If they have, then there's a good chance that they've not identified any problems with the pregnancy. They're on prenatal vitamins. They're getting regular screens, those sort of things. And then find out when the labor pain started. Does the patient feel the urge to push or move their bowels, which would indicate that the baby has made its way into the birth canal? And look at the vagina to see if they're crowning. You certainly can lay your hand over the uterus when the mother suggests that there is a contraction, and you can feel that uterus contract. You want to get a good set of vital signs to see how mom's doing. Now, here is the delivery of the baby's head. With one hand, you want to support the head so that there's not an explosive birth. Because once that head comes out, the head's usually larger than the shoulders. And if the head pops out, the whole rest of the baby may follow quickly. So during the contraction, you want to put some gentle pressure on the head so that you don't have an explosive birth. And you want to support the perineum, that area between the vagina and the rectum, as they're doing here with a piece of cloth. Again, depending upon the size of the baby's head and the size of the baby in general, the mother may experience a tear in the perineum, and by supporting it the way he is there, you're going to decrease the severity of that tear. Findings that might indicate that you're going to have to resuscitate this baby when it comes out is that the mother had no prior prenatal care, that this baby is being born prematurely, that the labor was induced by trauma. Now, typically where we see labor induced by trauma, it's usually abuse. It's not uncommon for a pregnant woman, particularly later in her pregnancy, to be abused by her abuser, whether that be her husband or boyfriend or whatever. And find out whether or not she's had, is this multiple births? Are we dealing with twins? Findings that might indicate the need for neonatal resuscitation also include, did she have any pregnancy problems? Has there been any sort of placenta previa where the placenta has detached from the uterine wall before the baby was actually born? Does she have any history of a breech presentation where perhaps the buttocks was the presenting part in a previous pregnancy? Was the labor induced by drugs if she were taking illegal drugs? And when the water breaks, did she notice any meconium staining? You may have to get additional information from the caregiver, the husband, because the mother, if she's in really uncontrolled pain and panting, may not be able to give you much information. So we're going to talk about normal childbirth first. Again, remember this, the role of the EMT is that EMTs don't deliver babies, the mother does. Mothers have been delivering babies since the beginning of time without any help from anybody. So your primary role is to determine whether or not the delivery will occur on scene, and if so, assist the mom in delivering her baby. You want to prepare the mother for delivery by controlling the scene. You want to make sure that you put on proper personal protective equipment. I highly would recommend head cover, face shield, gown, and gloves. If the amniotic sac is not ruptured, it may, and amniotic fluid may spray all over you. Place the mother on a bed or a floor or the ambulance stretcher. Remove anything that's obstructing the vagina, and then get your assistant to open up the OB kit and try to keep the environment as warm as possible because these newborns, particularly if they're wet, can get really cold fast. So here's an example of how to properly drape a woman for possible delivery in the home. Uh, Typical OB kit, you're going to have things like scissors and clamps and tape and gloves and a bulb syringe and stuff to control bleeding and a bag to put the placenta in, those sort of things. You're going to need some clean sheets and towels. If you don't have an OB kit, you're going to need heavy flat twine or new shoelaces to tie the cord. You're going to need a towel or a plastic bag for the placenta, clean unused rubber gloves and eye protection, and head covering for the baby to keep the baby warm. It says here, are there legal or moral or ethical concerns for an off-duty delivery? And again, this all boils down to your decision as to whether or not you believe the mother can make it to the hospital before she has the baby, because it's far better to attempt to assist the mother in the delivery of her baby in a more controlled environment like the home, rather than trying to do it in the back of an ambulance. When delivering the baby, you want to position yourself for constant view of the vaginal opening. You want to be prepared for the patient to experience discomfort and provide emotional support, and communicate with the patient through contractions. Now, certainly encouraging a mother to close her legs and things like that when she's in active labor or major no-nos. However, you could, during times where the head is delivered and you need to quickly suction the mouth and nose, you could have her pant through that. If she's panting, she's less likely to push. So that would be something that you could do. Keep someone at the mother's head, position gloved hands at the vaginal opening when the baby's head starts to appear, and as we saw in the pictures, place a hand on the baby's head as it bulges to prevent a sudden uncontrolled expulsion of the baby, and place one hand below the baby's head as it delivers, because again, the mother may also have a bowel movement while delivering the baby, and if that does occur, or there's a lot of blood or fluids that are below the baby's head on delivery, you want to make sure that you keep their head up out of that. If the amniotic sac is not broken, you need to use your finger to puncture the membrane and allow the baby to come out of the amniotic sac. Once the head is delivered, look to see if the umbilical cord is wrapped around the neck, and if it is, slip it off the neck of the baby, and then suction the airway at the perineum before the shoulders are delivered and the rest of the baby is delivered. Now, when you help deliver the shoulders, you're going to just gently tip the top shoulder down, because the baby should typically be on their side, head to the side. So you want to gently guide the head down to bring that top shoulder out, and then guide the rest of the baby up to bring that bottom shoulder out. You want to support the baby during the entire process. Remember, they're very slippery, so get a good hold of them. Then you want to assess the airway. You've already should have done some suctioning to the mouth and the nose at the perineum before the baby was born. Note the exact time of birth. And here is just pictures of delivering the baby. Head comes out, head to the side. At this point, I would suction, tell the mother to pant. I'd be suctioning and getting the mouth and nose clear, noting whether or not there was any meconium, and then guide the top shoulder down and then the bottom shoulder down. But get a really good hold of that baby, because they are going to be slick. And here they are removing the baby. And this ends part one. As we look at part two, we'll look at caring for the baby once the baby's born, as well as complications of pregnancy. So with that, if you have any questions, you certainly know how to get a hold of me, and we'll be talking to you soon.